Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Good afternoon. So you all heard the elegant lecture given by Dr. Nicholson. He showed the heart muscle, heart valves, and how they function, and how important the function of each and every structure of the heart to do their job to effectively pump the blood so they don't have the heart failure. But somebody has to coordinate all these things. These activities need to be coordinated. The upper chambers, the lower chambers, they all need to coordinate with each other. So somebody is giving these instructions, and that is the electrical system. So the electrical system in the heart is very important part of the heart, and it's very complex too. And that's where we have a subspecialty in cardiology called electrophysiology, where we look into some of these electrical details and take care of some of the problems. In fact, I'll start with the last question asked, came from somewhere here, about the leaky valve and the pacemakers. Dr. Nicholson explained partly, but there is one area where you can use the pacing function to minimize the leaky valve, and I'll come to that at the end of the talk. So electrical system is really very important in coordinating all these activities so the valves, even the valves, work properly. So let's get started, and I'll take you through a lot of pictures. So it's mostly going to be show and tell. There are a lot of EKGs that you'll come across, but you don't have to really pay attention to that because that's just for me, but I'll make it very simple for you to understand what exactly we look at it. Here's the heart, here's the chest. When you open the heart, the front wall, this is what you see, the heart. And if you open the heart itself, inside you will see all these various structures. I think Dr. Nicholson showed the echocardiograms where you saw these valves moving, and especially particularly the one valve that he showed in his picture was this valve called mitral valve. As you can see, it is a nice complex valve which has attachment to the muscle, and these are called papillary muscles, these two, and the valve really is tethered to the heart muscle. So say for some reason if the heart muscle is not working well, if this heart muscle is not working well, this tethering goes bad, and then that can leak. So I'll show how the valves can also leak if electrical system is not working well. But here what I want to show you is the electrical system itself. I cut the heart in different ways to show the electrical system. If you look at this right here, you're looking from the right side of the heart into the heart, and here is the area called sinus node. Now that is the main generator of the heart. That's what generates the electricity, and then this electricity, if you look at here, this is the same thing in this view, so it's called SA node. And then electricity comes down. First it goes to the upper chambers, and then upper chambers have this nice fine electrical network. And then upper chambers excite first because the electrical impulse goes to the upper chambers first. And then it comes to the central area called AV node, and from there it goes down this wire. It's called His bundle, there's a name for it, and then right bundle, left bundle. So the electricity is carried over to the lower muscle, and then the lower chambers squeeze. And all this happens in a very nice coordinated fashion because The electricity has to generate in the SA node, go down the AV node. There's a little delay, so the upper chambers squeeze first, and the blood is emptied into the lower chambers, and then it keeps repeating itself, and that's the heartbeat. So how do we actually measure the electrical activity of the heart? We can get the signals from outside the body. That's EKG. A lot of you must have already had one where you go to the doctor's office, they put all these wires. In fact, several wires, so you're looking at the electrical activity in different angles. That's why we call it a 12-lead EKG, because you get 12 different angles of electrical activity. And this is how you get the EKG right here. This is the 12-lead EKG, and then you can see lead 1, 2, 3, AVR, AVL, AVF. They're names, but what I'm trying to say is that we have 12 angles that we measure the electricity from. And how is this electricity generated in the cell, heart cell? There are sodium ions, potassium ions, chloride ions, calcium ions. They all go back and forth across the heart cell membranes, creating these electrical impulses. We don't have to go into the details of that, but I just want you to know that these electrolytes do make a difference. That's why we need to watch the electrolytes to maintain a proper electrical activity of the heart. As you can see here, if you actually put a little electrical wire inside the heart and record it, this is how the recording is going to be. But when you measure from outside the heart, what's happening is all these electrical activities, these things outside, are summated like a complex like this. This is finally what you see when you do EKG from outside. And as you can see, this is called P wave, the activity of the top chamber. This is called QRS complex, the activity of the bottom chamber, because the electricity is really high voltage from the bottom chamber because of thick muscle. And then this is called T wave because there's a recovery thing. And this is how this EKG is. As you can see P, QRST, P, QRST, P, QRST, and that's what you see on an EKG. So this is another little different way of showing and in a better picture, but essentially I'm showing the same thing, SA node, AV node, and this more realistic picture. If you really cut the heart, you don't see these bundles, but we can measure all these things with the wires. So what we do is then we sometimes go inside the heart and measure all these electrical activities from inside the heart also. So if you measure from inside the heart, this is how you see those electrical activity. So this is what happens when the electricity is working properly. As you can see, here is the sinus node where the electricity is starting, and it's going to the upper chambers first, and then through the AV node to the lower chambers. And as you can see, that makes the heart squeeze like that. And here are the valves. In fact, this one only shows just the AV valves, but then you also have other valves called semilunar valves, which I'll show in a different pictures. So as the heart pumps like this, and then it's pumping blood to the body through the arteries, and then blood comes back through the veins to the right side of the heart, and then that's how the circulation runs. This is the heartbeat, normal heartbeat. So the electrical things lead to the mechanical activity of the heart. So what can go wrong? So far what I showed you is the normal activity. So electricity can go wrong. Then when it goes wrong, it's called arrhythmia. That's the term. Rhythm goes wacky, so you call it arrhythmia. So an arrhythmia is a change in regular beat of the heart. The heartbeat may seem to skip a beat or beat irregularly. It can be very fast or very slow. Those are arrhythmias. So you can have an extra beat, a skipped beat, a fast heart rate, or a slow heart rate. Normally, for the body, we need a heartbeat anywhere from 60 to 70 beats per minute. And when we run, it may come up to 110, 120, and that's what we advise. When you do exercise, we bring the heart rate up to about 100, 120. And then when you settle down and relax, it should be around 60 to 70. That's the ideal heart rate. So what causes an arrhythmia? Many times there is no recognizable cause. Everybody asks me what causes arrhythmia. Arrhythmias happen when things go bad over a period of time. If you're not heart healthy, you're not eating right, high blood pressure, heart is working hard, it gets stretched out, all the muscle that is built nicely is now stretched out, the electrical system also gets stretched out. And then the beat generation and the beat conduction can go wrong, and that's how you end up in arrhythmias. So you can't actually pinpoint one particular cause when you ask the question. But sometimes, the overacting thyroid, a lot of smoking, a lot of caffeine use or diet pills can cause those problems. Or even sometimes cough syrups, which have some medicines like bronchodilators, can also cause arrhythmias because they excite the muscle. So there are three mechanisms how the arrhythmias happen. One is called automaticity, that heart is working automatic anyway. We don't have to think, our nervous system doesn't have to tell it. So that automatic activity, when it goes bad, it can go either fast or too slow. So the automaticity can go bad. There is another thing called triggered activity, but I don't think you guys need to get into the details. The third thing is called re-entry, where the electricity gets into a short circuit. Instead of traveling down the heart nicely, it makes a loop and gets a short circuit, and that's called re-entry. So these are the three basic mechanisms how the rhythms can go bad. So here's the slow heart rate. Well, let's start with the slow heart rates. How can the slow heart rate affect our body? Now here, this is just a slow sinus rhythm. It's not a bad thing. A lot of people, in fact, a lot of healthy people have that, and it's not a problem. It's called sinus bradycardia. Sometimes the interval between the atrium and the lower chambers can increase a little bit, called first degree AV block, not a problem. A lot of people have these things, they live with it, not a problem. And sometimes one of these extra beats can get blocked, may not conduct to the lower chambers. There you feel the skipped beat because the beat did not conduct, and you feel this heartbeat is called skipped. So all these are not serious. They're benign, not a problem. And here I'm showing a little bit more serious condition, not serious that people don't crash, but they can get dizzy or pass out, and that's the electricity does not conduct properly from top chambers to the bottom chambers. It gets blocked there. See how this beat did not conduct, and the next beat is conducting now? So this is called 2-to-1 AV block. So if you have a problem like the conduction is not good, then you need a pacemaker. So this heart needs a permanent pacemaker. And here I'm showing the same thing in EKG. So when you come to the office or the emergency room, when we do an EKG, and you can see that this P wave from the top chamber conducted to the lower chamber, but this P wave did not conduct to the lower chamber. And then again the other next P wave conducts, the next one blocks, next one conducts, next one blocks. That's called 2-to-1 AV block, and that's a indication for permanent pacemaker. And you can see in the animation form, here is the normal sinus rhythm, and here is the AV block where this one is beating twice. The upper chambers, these are the upper chambers, this one and this one. They're beating twice the lower chamber. The lower chamber is going low at a rate of maybe 30 or 40. Then people feel weak, not up to the mark. So when you put the pacemaker, that gets corrected. And this is what we do. So this is the pacemaker. Usually we keep it under the skin right here, just above the muscle. And then two wires come like this to the heart. And here's the wire, and it's pacing. So electricity, instead of coming from the own generator of the heart, now you implanted a generator that produces the electricity and runs the heart. That's a pacemaker. And this is how we implant the pacemakers. You see, we go and prepare, we sterilize the area, put a needle, and in fact, see, get this vein. See, this wire is in this vein right now. and then we put a plastic sheath on it, take the wire out. Now the lead, this is the wire that actually goes into the heart, and you can see that it comes at the other end, see, into the heart like that. We see all this under X-ray. We go and actually there's a screw at the tip of the lead, and we turn it. Once we turn it, actually you screw that into the muscle, so now it can pace the heart muscle, and that's how we do it. So that's the pacemaker for slow heart rhythms. So that is about the slow heart rhythms. There's also a condition called third degree AV block, where the electricity actually does not conduct from the top chamber at all. Then also we put a pacemaker. So anything 2-to-1 conduction block or no conduction at all, we need a permanent pacemaker, because the main command center is in the top chambers, and if the electricity from the top chambers is not conducting to the bottom chambers, we need a permanent pacemaker. So that is about the slow heart rates. Now we are moving on to the fast heart rates, and this is a little bit more complex, the fast heart rhythms, and that's where our specialty comes into effect. There are a lot of fast heart rhythms that come from the top chambers, and they're called supraventricular tachycardias. As you know, the bottom chambers are called ventricles, and anything that comes from above the ventricle is called supraventricular tachycardia. Tachycardia means fast heart rate. So there are several types of supraventricular tachycardias. One is sinus tachycardia. Sinus is the main generator that runs the heart all the time. When we run, it increases the heart rate. So that's called sinus tachycardia, which is normal. Usually we need that when we exercise and things like that, but sometimes it can be inappropriate. There are some patients where the sinus node takes off much faster than it should be. Then it's called inappropriate sinus tachycardia. We see that condition sometimes. Usually we treat that with a medication. Then there is a condition called AV nodal reentrant tachycardia. These are all fancy names, but you don't have to remember any of these names. I'm going to show one picture, you'll remember all these things. So in fact, I'm going to quickly skip these names and show the picture so you will understand what I'm talking about. So this is the picture. If you look at it, so we have two top chambers, two bottom chambers, and there's a sinus node right here, and this is the AV node, and this is the His bundle. So what happens, the electricity near the sinus node can go round and fast, faster than it should be. Then it's called sinus tachycardia, whether it's appropriate or inappropriate, right? So if it's inappropriate, usually it's sinus reentry. There's a reentry mechanism going on there. The same kind of reentry mechanism which I showed you as a short circuit can happen in the AV node, and that's why you call AV nodal reentrant tachycardia. So the names go by the area where it happens. So here, if the short circuit is right here, then it's called atrial flutter. So there are different names depending on where the short circuit happens. Sometimes people can have an extra electrical connection, and short circuit can happen like this, then it's called AV reentrant tachycardia. We don't have to remember any of these names. All that you have to know is that short circuits can happen that can drive the heart very fast. And those are all supraventricular tachycardias. And it can be on the left upper chamber also. It's called atrial reentrant tachycardia. So it doesn't matter. Depending on the location, the names are given. And these are all the different kinds of supraventricular tachycardias. And I'll show one by one. Here is the EKG that just shows one extra beat from the top chamber, like one extra beat, not the sinus beat, but the extra beat, and that's called premature atrial contraction. Everybody has them, no problem. That is not a problem at all. But if somebody smokes, has a bad lung condition and problems like that, then they can have problems like sinus tachycardia right here. This heart is going very fast here, more than 100, 110. And the COPD patient with bad lungs, they can have a lot of different areas in the top chambers firing apart from the sinus node, called multifocal atrial tachycardia. So in this case, we can give some medication, but the main problem is with the lungs, and we are supposed to take care of the lungs to improve the condition. That's called multifocal atrial tachycardia. Now, this is called AV nodal reentrant thing, because the AV node right here in the center of the heart has two different types of electrical fibers, and sometimes those electrical fibers conduct the electricity, like electricity comes here, goes through the slow pathway and comes up the pathway and makes a short circuit called AV nodal reentrant tachycardia. And there is an elaborate way of explaining it, but you don't have to get into the details. And then they have this tachycardia called AV nodal reentrant tachycardia. Now, this is the only little fancy EKG I will show you. The only reason why I'm showing this EKG as a fancy EKG is what we think. I want you to understand how we think about this electricity. Okay, you don't have to understand this at all. You just have to know that electricity is a little complex, that we go through all that process to make it easy. But here is a EKG where you have SVT on one end of the EKG and the sinus rhythm, the regular rhythm on the other end. So this is sinus rhythm, P, QRS, P, QRS. Here, the P is right here after the QRS, and this is AV nodal reentrant tachycardia. So how do I go on explaining it? So this is how we explain. So you look at the normal beat where P, QRS, but then the next beat is an extra beat that came from not the sinus node, but a little different area, and that leads to increased duration between P, QRS. So now the electricity is going through the slow pathway, going to the ventricles, and comes up the fast pathway into the atrium. So this is all a jargon for you guys, I know. But this is what we look at when we are looking at the EKGs. That's how we come to the diagnosis. So it is a complex process for us to think about. But I'm just showing it only to make you understand that electrical thing can be a little complex sometimes, and that's why we have a subspecialty in this area. So once again, coming back to that AV nodal reentrant tachycardia, how this is initiated sometimes, and this is a 12-lead EKG on a AV nodal reentrant tachycardia. Here the heart rate is going at 180 to 190, by the way. So when the heart is running 190 rate, it can cause problems. It can cause dizziness, people can pass out. Usually people don't die from this. It's just the passing out and not feeling well, getting short of breath, that kind of symptoms. But death is not one of the things with the SVTs. So we can give a medicine. Usually they end up in emergency room when this happens. We give this medicine called adenosine, and then they usually get out of it right away. So it's a easy rhythm to get one out. But then we have to think about fixing it. You know, if that short circuit, once somebody has it, it's going to keep coming back. And they keep coming back to the emergency room. So what we do what is called as a radiofrequency ablation. As you can see in this picture, what we do is we put catheters into the heart. These are the wires, catheters we call them. Then I have one here that actually is putting a little burn-like thing in the heart to disturb that re-entry short circuit, and it's cured. And this is called radio frequency ablation. So when we do that, it's curative. More than 90% of the times we cure the condition. The chance of some problem is less than 1%. So this is an easy one. AV reentrant tachycardia is another condition where some people have an extra electrical connection in the heart, and that we can see here in the picture right there. That's an extra electric connection called accessory pathway or bypass tract. If the electricity goes through the bypass tract, then it's called Wolff-Parkinson's-White syndrome. And if somebody has this kind of extra connection, they can also have short circuits, and that also we go into the heart and we burn that. Because once they have that kind of extra connection, they can make re-entry circuits, and sometimes it can be dangerous also. This is how EKG looks in WPW syndrome, Wolff-Parkinson's-White syndrome. And they can have arrhythmias like this called AV reentrant tachycardia. Sometimes they can have bad rhythms and there is a risk of sudden death. It's very rare though. It's less than 1 in 1,000. But people with this kind of condition can sometimes die. So we bring them and we actually get rid of that extra electrical connection by the catheter. We go in and burn it, and then it's gone. So usually these kind of people end up with us in their 30s, 40s, and then we get rid of those bypass tracts, and they're usually curative. So it's taken care of. So some people have an extra focus firing like here called atrial tachycardia instead of the sinus node. In that case also you have an EKG like this. It also gives similar symptoms. The heart runs kind of hurries all the time, and it's not good because heart going at 180, 190 or pump, is not pumping the blood effectively. So it can be a problem. Once again, what you do is you put a catheter, you go inside, you burn, and you get rid of it, the focus, and it's gone. So all these crazy things, whether extra focus or a re-entry short circuit, you can put these catheters, do radiofrequency ablation, and fix those problems. So flutter is another condition where the electricity actually goes in circles around this ring-like structure. As you can see here, you can actually record from inside. This is actually animation of the flutter. See how the upper chambers are going at their own rate and the lower chambers don't. If you look at the EKG, you can see all that sawtooth wavy thing that's from the upper chamber, and not all of them go to the lower chambers, which is a good thing. If all of them go to the lower chamber, we'll be in trouble, and a few of them go to the lower chamber, and you can see the difference. So in fact, you can put a catheter like that and record that whole electrical activity, and put another catheter like that and make a burn, and it goes away. So there are a lot of SVTs you can actually fix by doing what is called as a radio frequency ablation. Now there is one condition called atrial fibrillation. It also comes from the top chambers. Now this is a little different from all the other things that I just showed you. In this, the electrical activity is really chaotic, and this is by far the most common rhythm problems we see among the people these days. In fact, a lot of patients who come to us for rhythm problems are for atrial fibrillation. And as you can see, what happens is over a period of time, the heart upper chambers get enlarged and the electricity goes all wacky, and electrical short circuits. There are multiple wavelets going all over the place, and if you actually put a wire at any one place and record, there will be 300 to 400 beats per minute. Luckily for us, the God created a barrier. All these beats don't go through this AV node, so only 100, 120 or 150 beats can go through, so that the heart rate is very irregular and erratic. It's not a normal sinus rhythm where it maintained in a regular heartbeat. So when it's irregular like that, the heart pump becomes very inefficient, and not only that, these upper chambers, they're not squeezing like they usually should, and the blood stays in the upper chambers and becomes clot, and when the clot goes to the brain, one can have a stroke. So there's an increased risk of stroke in atrial fibrillation. So this atrial fibrillation is a little bit of a nuisance rhythm, very common problem, little difficult to treat and manage, but we do a good job these days explaining and educating the patient. It's very important for you to understand how complex this is, and learn a little bit more about atrial fibrillation to manage effectively in terms of controlling the rate, even try to fix the rhythm itself, which is sometimes difficult, and also preventing stroke in atrial fibrillation by taking the Coumadin and like medicines properly. So atrial fibrillation is a very common problem. That also we do ablation also for atrial fibrillation, but this is a little complex ablation, not a straightforward simple ablation like I was explaining in other conditions. Here you actually have to put a lot of catheters. You have to go into these veins called pulmonary veins, and you have to burn inside the pulmonary veins. So it's been a little bit more complex ablation, and there are some doctors who are just specialized in that. In fact, we have one person in Washington by name Dr. Bowie. She does these things. I don't do this. But it's doable, and in young people we advise that they should go for ablation. But in older people we try to treat with the medication, and sometimes we have to give a shock to get them out of it. So that is all about the rhythm problems from the top chambers. Now there are rhythm problems from the bottom chambers, and these are a little bit more serious. So let's get started. Here is one slide that is showing an extra beat from the ventricle. It's called premature ventricular contraction. Once again, this is also very common, seen in a lot of people. It's not a problem. But what happens in heart, when the heart gets damaged and there's scars, this is how it gets enlarged. See how it's enlarged and the blood doesn't flow properly. This is what heart failure patients do. So heart failure patients usually have a stretched out muscle that has a weakened muscle and a scar and things like that, from where the electrical impulses can come, or the electricity can go around the scar and produce a rhythm called ventricular tachycardia. Now this is a dangerous rhythm. If somebody has a damaged heart, had a heart attack, scars, the electricity is going round and round the scar, that can lead to this kind of rhythms that can suddenly kill people sometimes unexpectedly, even though otherwise they are doing okay. And that's why when heart gets damaged to a certain extent, we put this device called ICD, implantable cardioverter defibrillator, to make sure that it will watch the heart all the time and get you out of it when you go into it. And that's what Dr. Nicholson was mentioning at the end of his talk, that if somebody has a bad heart with ejection fraction of less than 30%, we usually put a implantable cardioverter defibrillator to prevent unexpected sudden cardiac death. We all are going to die someday. That's not going to prevent that. The pump failure, we're not going to prevent that, but unexpected rhythm, just short circuit, that we can tackle the problem by giving a shock. So ICDs work well if used appropriately. They're very good devices, and they're also pacemakers, and I'll talk a little bit about it. And this is the animation of a ventricular tachycardia, where, as you can see, the rhythm is mostly from the lower chamber, and upper chambers are beating at their own usual rate. And this is a dangerous one, where the blood pressure drops precipitously to about 60 or 50 or even lower, and patients actually crash. And this is the defibrillator. In fact, this animation shows how the defibrillator works. See, electricity comes, boom, shocks and stops it. See, that's the defibrillator. This is the defibrillator. The heart is beating at its normal phase, and now it goes into the bad rhythm. Now that's the one that people crash, and then now it gives electricity, boom, gets them out of it. So that's how the defibrillators work. So defibrillators are also pacemakers, by the way, and here's the EKG, and you can see that the whole thing on the EKG, how this was a normal rhythm, goes into ventricular tachycardia, and it gives a little pacing and gets you out of it. Here, of course, it gives a shock. The one before, it was not giving the shock. It was actually getting the heart out of it without giving the shock, with just pacing. Here, the pacing does not work. The heart is still in the bad rhythm, so it gives a big shock and gets this patient out of it. See, here's the bad rhythm. Now electricity didn't get out, big shock, out. It's monitoring. It's a pretty smart machine. It's monitoring the rhythm all the time, and it knows when it goes into it. You can program from outside. You can set criteria. You can tell the machine when to react, when not to react, and all those things. So it's a science by itself, but in a simplistic language, yes, it's automatic. It takes on its own. So there is one more rhythm which is even worse than ventricular tachycardia. It's called ventricular fibrillation, where the heart really goes wacky, as you can see. Just basically it's doing this, fluttering, it's shivering basically. It's not squeezing at all. In this case, people just die right away, and there also the ICDs are very effective. So, are arrhythmias serious? Well, I just showed you a bunch of arrhythmias. Some are serious, some are not. In fact, majority of the arrhythmias are not serious. So just because you heard the diagnosis of arrhythmia doesn't mean that you're in a bad shape. So you just have to understand whether it's coming from the top chamber or bottom chamber. Is it coming in a bad heart, damaged heart? Is there scars? That's when we should worry. If somebody has a bad, damaged heart with a lot of scars, that's when we should be a little bit more careful and that's why we have the defibrillators these days to secure that. But majority of the problems are not serious. So how common are these arrhythmias? All of us have them, by the way. If I put a Holter monitor on every one of you or on myself, if you see it the next day, we all have arrhythmias. It doesn't mean anything. We need to figure out if they're bad. And usually they're seen in the middle age group, and as we get old, the incidence increases, particularly the atrial fibrillation. 40% of rhythm problems we see among patients is atrial fibrillation. So it's very common. So what are the symptoms? Actually, Dr. Nicholson explained a few of those things. It's the same symptoms, really. But the additional symptoms you may have are palpitations. You actually may feel irregular heartbeat. Some people can tell, some people can't. So if you feel the heartbeat, it's called palpitation. Well, we feel palpitation. You get a bad news and then your heart goes fast. You feel palpitations, right? That's a normal thing. That doesn't mean anything. But sometimes patients who have atrial fibrillation can feel the irregularity of the heartbeat, and then they should alert the doctor. They should let the doctor know that I feel palpitations that are irregular. In fact, what you can do is you can make some intelligent observations so that you can tell the doctor. When something happens, don't panic. Check the pulse. I think every one of you should know how to check the pulse. I check this in the office. A lot of people can't. I learned that in my 3rd grade. So I always wonder what you guys play. When you were kids, you should play the game, doctor game, you know. So everybody should know how to check the pulse with 3 fingers put on the bone here nicely. And the reason why I say you should learn with the 3 fingers is you will be able to feel the pulse even when it's weak. Everybody feels the pulse when it's normal, but you should be able to feel the pulse even when it's weak. And if you can do that and not panic, take a deep breath, check it. In fact, what you should do, you should check the pulse when you're normally sitting like this and see how it is. So when it goes wacky or fast, you don't have to really count it, but you can say it's going fast. Like you can say it's going very fast or not that fast, something like that. That gives us some clues. That gives us some idea. So we can think better. We can diagnose better. See, a lot of times it's a game of catching it, you know. So it happens at home. I give you this machine to monitor for 24 hours, and by then you don't catch it because nothing happened. So if you can do these observations at home, we'll know. So everybody should practice that. In fact, there should be a blood pressure machine at home. There should be a thermometer at home. All these little things, they all help. And if you all learn how to take vital signs, that helps quite a bit. So that's one of those, just the palpitations. You can feel dizzy sometimes, bad dizziness, pass out, and heart failure. If somebody is in atrial fibrillation, they're driving the heart at a rate of 120, 130 all the time, the heart gets weaker, they can go into heart failure, what Dr. Nicholson was talking. If somebody has irregularity, heart is not coordinated, they can have problems. If somebody has a bundle branch block, one of the bundles that I showed you is not conducting, now the heart muscle, instead of getting excited from both sides at the same time, is doing this, because one side gets excited first and the other one next. So it's doing like a beach ball instead of like a heart pump. And then they can also go into heart failure. So we look into all these details and we try to fix. And let me show you some of the things what we do. Say medical. First, if somebody has a rhythm problem and come to us with these symptoms, we give them some machine and then we diagnose the condition and we can give some medication. And there are a bunch of medications like I just mentioned here on the slide that act at different levels. There are some with a lot of side effects, there are some without much side effects. And we do what is called as an EP study, electrophysiology study, where we put the catheters into the heart, we stimulate the heart, we beat it back and forth and see what it does. We can produce the short circuits if there are, and we can produce the bad rhythms if there are, and then diagnose the condition. So we do this only if we can't catch it outside usually. And this is how we look inside the heart. We put a lot of catheters under X-ray. You can see this is the electrical activity we measure from inside the heart. So there are ways to diagnose these conditions in the lab. but we try to catch them before it actually goes to the lab through the monitors and all those things. So once we diagnose, I just mentioned the medication, and the other things we do are these defibrillators. Like I was showing you some of the animations. You can put a pacemaker or a defibrillator depending on what rhythm you're treating, and this is how it looks on X-ray. And we also use that extra smart ICD to actually resynchronize the heart. And here is the picture of that. What happens is we have to put 3 wires into the heart, like you can see here, 1 to the top chamber, 1 to the right bottom chamber, and 1 to the left bottom chamber, which we go through this vein called coronary sinus into this branch and put the lead. And this is to not only treat the slow rhythms, but it can also treat the fast rhythms because it can give a shock. In addition, it is also trying to resynchronize the heart to treat the heart failure. And that's what I think Dr. Nicholson was trying to mention a little bit, and trying to answer the question of leaky valve and pacemakers. So what happens is, if the heart muscle is damaged and this muscle is not squeezing well, and I showed you, remember those papillary muscles inside, they're not working properly, so the valve doesn't co-op nicely, it leaks. So when you put the extra wire into the heart and then you try to synchronize the heart muscle to squeeze at the same time, so the papillary muscles also squeeze at the same time, so valve closes properly and you don't have the leaky valve. And so you can treat the heart failure by resynchronizing the muscle and also minimizing the leaky valve at the same time. I'm almost done. I'll answer your question. So that is the last part I think this is the last slide. This is just to show how we put that extra lead in the heart. And this is a little bit a tricky procedure. How we put the catheter in there and we inject the dye into the vein, take a picture, and then we put this wire in there, how it goes. These are all little fancy, sophisticated procedures, but we've been doing good. We do a lot of those at Washington Hospital and do not cause many troubles. So I think we should use all this technology to help the patients. Okay, so that's the end of the talk. We talked about normal mechanisms, fast rhythms, slow rhythms, rhythms from the top chamber, rhythms from the bottom chamber, and what we can do to fix them. So you guys have any questions?
With a pacemaker, if a battery needs to be replaced, maybe in a year or so, when the battery does need to be replaced, can you reevaluate the heart and determine if any of those symptoms need to be changed and then recalibrate the heart, so to speak? Or do you need to have a complete change of the pacemaker?
We do that on an ongoing basis. Any patient with a pacemaker, we follow them every 3 months, and when they come, we interrogate the pacemaker. When we interrogate the pacemaker, there is a lot of data the pacemaker tells us. In fact, the pacemaker can record if there are fast rhythms happening from the top chamber, how much it paced, how much the heart was on its own. It has a lot of diagnostics that we can look into.
When you, as you mentioned, when you change or when you check the pacemaker every 3 months, what if it continuously say, the readouts continuously say no events?
No events? What events are we talking about?
You know, I can't really say because my father has his pacemaker changed.
That means there's not a whole lot, like tachyarrhythmias are not happening. That's what it means. So you need to be specific about events. That's why, so you have a lot of diagnostic in the pacemaker. It all depends on what kind of information you want to gather. Say suppose if somebody is having a lot of atrial fibrillation that pacemaker records, then we need to treat it. So say suppose if somebody comes to me and then say they're paced 80% of the time. I then look into the details as to can I make some changes in the pacemaker so it's not paced that much, because we don't want the heart to be paced that much. So we decrease the lower rate a little bit to let the heart work on its own, or maybe adjust the medication so they don't have to be paced as much. So there are several little things that it's a lot of details, by the way, a lot of science in there. We look at all those things, and that's why we check every 3 months to see if any of these things are happening, to see if the lead is working okay, to see if the battery is okay, and if it needs any adjustments in programming. And the programming is very, very complex, by the way. So that's what we learn over years about how to program the pacemaker appropriately. Pacemakers evolved quite a bit in terms of the dual chamber pacemakers, how they coordinate with each other. There are a bunch of clocks, how they talk to each other. There's a rate response mode, how that can be programmed. There are several things, but that's what the specialty is all about. Electrophysiology is all about, that we learn all those details and then we program the device every time the patient comes, we make some changes.
Hello, doctor. With regards to arrhythmia, how does one know when it's time for a new treatment with regards to maybe surgery of some sort?
New treatment, okay. They say, for example, with the medication, if things are controlled, then you know you're okay. Suppose you still have the symptoms, you think the rhythms are going irregular, and that's when you know you need the surgery. We have to, of course, get into specifics of it. For example, if there is SVT, one of the 6-7 rhythms that I showed, if somebody keeps having those episodes in spite of us giving medication, then you know it's a time for not really surgery, but what we call as radiofrequency ablation. It's done through the catheters. So if the heart rate is too slow and you try to adjust the medication, but if it's going too slow, then it's time for a pacemaker, then you know the surgery. So in spite of trying to treat with the medication, if your symptoms are not fixed or you still have the problem, then it's time for surgery.
Dr. Reddy, I haven't heard you talk about cardioversion, and can you tell me a little more about that with atrial fibrillation? And what is the percentage that it works the first time or the second time?
Those numbers are all over the place, but the way we do is this. If somebody has atrial fibrillation, we look into some of the details as to what kind of heart do we have. Is there an enlarged left atrium? Is there an underlying thyroid problem? Looking at those things, say they don't have a thyroid problem, this is just a high blood pressure for a long time, the upper chamber is enlarged a little bit. First time or second time they're coming to my office, I give some medication, they didn't get out of it. Now I say, let's cardiovert this. The reason why I want to cardiovert as soon as possible is because atrial fibrillation begets atrial fibrillation. If the heart is in atrial fibrillation for a long period of time, it likes to be in it rather than get out of it. So we like to get it out. It's called remodeling. There's a concept called remodeling. So we give one quick attempt of cardioversion, but before cardioversion, we do have to make sure there are no clots in the heart that might go to brain and cause strokes. So sometimes we can't do it right away. Sometimes we go and do what is called as a transesophageal echo and look inside the heart to make sure there are no clots and give the cardioversion. Or sometimes we give anticoagulation with a Coumadin for a month before we do cardioversion. So we do one attempt like that. Say suppose if they go back into atrial fibrillation, sure, didn't work. A lot of times if it's a young patient with not much enlarged heart, once you get them out, they're okay. They don't go back into it. So then you give some medication. Second time around, you give some medication, you give one more attempt of cardioversion. If they stay out of it, then it's good. So our goal is to try and get them out of it as soon as possible and keep them with some medication. Sometimes we are successful, sometimes we are not. And especially if they're elderly, hearts are enlarged, then we lose that game at some point. And then we say, okay, it's time to just treat with the rate control. There are a lot rate control. In other words, you're not fixing the rhythm itself, rather you're just controlling the rate and then leave them in that rhythm and keep them with anticoagulation. Yeah.
Yes, doctor. I have a irregular heartbeat, and I've taken a Tichycardia for 2-3 years, and that didn't work. And now he put me on an amiodarone, but I have side effects from it, like thyroid, and I'm taking Synthroid for that. Is there any of these other medicines that don't have so many side effects?
Yeah. In fact, there's a new medication that just came into the market called Multac, TAQ. Maltaq is nothing but amiodarone without that iodine moiety in it. So the iodine content of the amiodarone is the one that causes all these side effects, thyroid side effects and liver problems and lung problems. And the Maltaq, what they did is they took that iodine out. So it is not supposed to have any of these side effects. But there is one technical problem. The medicine is just released. Not many insurances are covering it, and we're having a lot of hard time. Even when I prescribe, I get this note back saying that it's not covered. So that, except that problem, I think it should pick up. So you will soon hear about it. It has been out for a year now. We're using it more and more, so that's a better drug. You could take that, yeah.
Well, let's thank Dr. Reddy